Okay, you guys can still hear me and see the slides?
Yes.
Yep. All right. Thank you for the feedback and thank you for the reminder to record. Again, my apologies for the miscommunication. But if you do have questions about the part that is not recorded or was not recorded, please reach out to me and I'm happy to go over it again with you guys. All right, so let's pick up where we left again. We were talking about complications of enteral nutrition. We discussed GI intolerability. Then we're going to diarrhea again. Diarrhea happens because of the high osmolarity of the ingredients, particularly the carbohydrates and the protein and the smaller amount of liquid that goes into the formulation. So how do we try to avoid this is obviously by making sure that we are providing additional fluid from on top of the enteral nutrition formulation. But once it develops, you have to make sure that you figure out other things that could be possibly worsening it or causing it other than enteral nutrition. So one thing, again, thinking as pharmacists, is that drugs could be causing diarrhea such as that we talked about constipation. They can also cause diarrhea. Think again when we're talking about liquid formulation and they do have sorbitol and how sorbitol can cause diarrhea. So if you are using liquid formulations, make sure to check to see if they do have sorbitol ingredients in it. Also infectious etiology, just to make sure that there is no infection, because if there is a GI infection, most likely that will present itself as diarrhea. And if there are some infectious diarrheas, some of them are treatable and others are more supportive care. So obviously you want to make sure that these are the causes of the diarrhea than an infection itself, rather than, sorry, the enteral nutrition formulation itself. If none of that is the case, then it's probably the enteral nutrition. You try to do a couple of other things. You change the formulation to something that has more fluid, or possibly just different ingredients that are more tolerable. We talked about the lactose, that it's generally not used in enteral nutrition formulation. So this was a more commonly used strategy in the past when there was lactose in the patient. You find that way that they are lactose intolerant and you switch to something that's lactose free. You add soluble fibers. So fibers, again, they are soluble and insoluble. There are some of them soluble and some are insoluble. If it's a soluble fiber, that means that your body is going to be able to absorb it, and with it, it will absorb water. Okay, so that would decrease the GI output. Insoluble fibers are fibers that your body is not able to break, so it's not able to absorb. So that will stay in the GI tract. And because it's an osmolar molecule, it will suck water out of your body into the GI tract, thus causing diarrhea. So you try to avoid that and you only add the soluble fiber. Use an antidiarrheal agent, like we were just talking about, loperamide, in moderation, obviously. And worst case scenario, you cannot control the diarrhea and you cannot avoid all the complications that can happen because of diarrhea. Then you have to switch to parenteral nutrition. Questions? All right. So these were the metabolic complications that can happen. These are not the only complications, but the main ones that we see. Some other complications that happen because of all that tubing access that we use. So the tube itself can be occluded, just because you're putting some solid ingredients there, mainly crushed tablets. Um, the enteral nutrition should be in a liquid formulation, so it's mainly going to be the tube itself. Sorry, the medications that are crushed. Malposition of the tube itself can happen as well. That also is likely because of the medications or that there is insufficient flushing. So flushing is just the amount of water that you flush the tube with to make sure that it's clean. You put the medication and you flush again and so on. So if you're not doing that enough, that can occlude the tube as well. And lastly, which is a horrible complication, is if there is inadvertent nasopulmonary intubation. If the tube, instead of going into the GI tract, it goes into the lungs. So you're pouring enteral nutrition formulation into the lungs. All right, so let's check our knowledge again. A patient is receiving enteral nutrition, begins to develop diarrhea. The provider turns to you, the well-educated pharmacist, and asks, hey, what can I do to treat this patient's diarrhea? Which of the following is a treatment strategy for EN-associated diarrhea? Is it change to high osmolarity EN product? 2, discontinue the product altogether? 3, change to an enteral nutrition product containing a higher soluble fiber content, or 4, give loperamide 4 milligram times 1. Could be more than one correct option. What do you guys think? Okay, got a vote, another vote. Okay, all right. So let's talk through this. First option, change to a high osmolarity EN product. So we talked about the osmolarity being the main reason for the diarrhea is because water is going to go to a higher osmolar compartment, right? So if I am dumping into the GI tract high osmolar ingredient, that will suck more water out of the body into the GI tract, then causing more diarrhea. So that should be the opposite, that we change to a lower osmolarity product. So 1 is incorrect. 2, discontinue EN product. It's so if you recall from the previous slide, it said like worst case scenario, you cannot fix it at all. You switch to parenteral nutrition, right? That would be the last ditch effort. So you have to do other trials of other things before you go there. You're not going to discontinue the EN product or switch right now to a PN, or discontinue EN product and leave the patient without nutrition. So that's why 2 is not correct. 3, change to an EN product containing higher soluble fiber content. So that is correct because we said soluble fiber is a fiber that is the body's able to break and absorb. And because it's an osmolar molecule and your body is taking it inside, it will take more water with it as well. So decreasing the content of solid and liquid content into the or ingredients into the GI tract, thus decreasing diarrhea. And lastly, give loperamide 4 milligrams. So we said that loperamide is an antidiarrheal medication. So it would help a little with that situation. So you could use it as well. So correct answers are 3 and 4. The question doesn't say select all that apply. If it's an exam question, I'll tell you select all that apply. So this was more just to get you thinking a little. All right. So medication administration. So these patients are going to need to be on medications, hence they are in a hospital or a long-term care facility or an assisted living facility, or anything that requires a little bit more attention than a patient who's home. You would rarely see a patient on enteral nutrition and staying home. So because they are sick, they need medications. And because they need medications, we have jobs. So how are we going to give them medications? So we talked about this before. The access point for the medications is, if possible, is going to be the stomach over the jejunum. And that, again, for several reasons, is because the stomach is a bigger organ compared to the jejunum, which is a much smaller caliber, right? So if you have a medication that's not available in a liquid, what are you going to do? You're going to have to crush it. So if you crush it and you put it in the stomach, if you put it in the jejunum, that will clog up the tube. It will probably not go well in the jejunum, and it will prevent enteral nutrition administration. Versus if you put it in the stomach, not a big deal. The other thing is that you're following the same path of administration of regular medications in general, right? So if it's a medication that needs to be exposed to the stomach low pH and you are bypassing that and you're giving it directly into the jejunum, it's not getting activated, right? So that's why the preference is always to give the medications in the stomach. Second point is that liquid dosage forms are preferred because of what we just said. Obviously, again, sorbitol, I probably mentioned this point several times already now, and you were sick of hearing it, but it happens quite often that there's a lot of liquid formulations have sorbitol in them. So we try to avoid having inducing diarrhea by that problem. Third point, which I kind of alluded to, is flushing the tube. So again, enteral nutrition formulations is going to be highly concentrated. It doesn't have a lot of fluid in it. So you have to provide additional hydration on top of it. So when you're using the medications, you're using that for making sure that the medication doesn't clog up the tube. So you flush before you give the medication and you flush after you give the medication to prevent the clogging of the tube, but also to provide hydration. So it's usually about 15 to 30 milliliters. The nurse has the regular flush, flushes the tube, that clears the tube, then puts the medication that's either liquid or crushed tablets, administer it there, then another flush to clear the tube, then give the medication. If there are several medications, you just have to follow the same process. Usually, you just use a smaller volume, about 5 to 10 mLs, versus if it's just one medication, then you give that volume. The main thing is that you do not mix the medications together because they can affect each other, and do not mix the medications with the enteral nutrition formulations. If you look at package insert of several medications, they will tell you if you can crush it or not, but it will tell you if medication can be crushed. It will say mix it with applesauce or mix with soda or something like that. So, but no medication should be mixed up with the enteral nutrition formulation. The other thing to worry about, which we'll talk about more next lecture, is holding the enteral nutrition for several hours for certain medications. For certain medications, that if you give too close to the enteral nutrition, they can be deactivated or they can affect the nutrition itself. So we'll talk a little bit about that. I think the last slide maybe of this slide series. But just something to keep in mind that there are some medications that you absolutely have to stop the enteral nutrition for hours before and after you give the medication. All right, so that is it for the enteral nutrition. What questions do you guys have?
Dr. Eid,
Yes, sir.
so when you hold the medication for 1 or 2 hours, is that like for like indicated for the medications that says that you shouldn't eat or like or you have to have an acidic environment for the medication to be absorbed? That's why like you have to hold it.
Yeah, so yes and no. So the last part about the acidic environment isn't necessarily applicable here, but the first part is taking a medication in an empty stomach is exactly what that is. So let me explain this a little. So let's say, for example, fluconazole. You guys have learned about fluconazole yet? I'm going to take that as a no. So fluconazole is an antifungal. That's a medication from class called azoles. Those need the stomach environment to be highly acidic for it to be activated and absorbed. If you give this medication with another medication that decreases acidity, that medication is not going to work. Do we give fluconazole in an enteral nutrition or an enteral feeding tube? Yes, and it can go into the jejunum. But generally, you try to avoid that because it needs to be exposed to an acidic environment. So mostly it's going to go into the stomach. But you don't have to hold the medication, the enteral nutrition for it because these two don't interact with each other. It goes into the stomach with a whole ton of enteral nutrition or no enteral nutrition at all, it ends up in an acidic environment, it will be activated. Versus if we're talking about something like, give me an example of a medication you guys have learned about that you need to take on an empty stomach.
A direct acting antiviral like my Myverit.
Okay, yeah, that's very specific. Um,
Tacrolimus.
what was the second one?
Tacrolimus.
Tacrolimus. Oh, okay. Uh, it's hard for me to go into these two drugs specifically without giving you too much details that are not related to enteral nutrition or parenteral nutrition. I'll give you the simplest example. That's something that I guarantee you'll see in your practice wherever you go, whether it's inpatient or outpatient. Levothyroxine. You guys have heard of levothyroxine, right?
Yes.
Okay. A lot of people have hypothyroidism, they get levothyroxine. That's a medication that needs to be taken by mouth, right? I mean, ideally. And it needs to be taken in an empty stomach. Can this be given in an enteral nutrition, in an enteral tube feed? Yes, but that's a medication that you need to hold um, enteral nutrition before and after. The reason for that is because whether you give it an enteral tube feed or you give it by mouth, it does chelate with cations. So calcium, magnesium, iron, copper, all these, if you give them too close to each other, they will bind and your body is not going to absorb the drug. So that's why you tell your patient when they take levothyroxine, you need to take this medication first thing in the morning, about half an hour to an hour, if not even longer, before you eat your first meal. Okay. So that medication, to tie to the point that you were asking about earlier, Ernesto, that medication can be given in enteral tube that ends up in the jejunum. It doesn't have to be going to the stomach for acidity because it's independent of the acidity. But it has to be separated from food if you're taking it by mouth or from a feeding tube because it can cleave with cations, which, not a surprise, enteral tube formulations have cations in them.
Hello?
Hi, is this Sean?
Yeah, I'm sorry. Did you need me to start the recording? I see that it's already recording, but I wanted to like jump in and confirm.
Hey, Sean. No, I thought that you are joining the meeting with us from the beginning and recording it, but
Hmm.
Farah pointed out that the lecture is not being recorded, so I started recording about like maybe 10 minutes ago or so.
Oh, okay, okay. I got it.
Yeah.
Thank you. I'm sorry.
No, no, thank you.
No problem. Bye bye.
All right, Ernesto, did that answer your question or confuse you more?
No, thank you so much.
You're welcome. How about anyone else? Is that clarifying, confusing? I don't want to deal with all that information. I wish you never bring it up again in an exam specifically. You guys are very quiet. I understand it's Zoom, but you can ask questions and express frustrations with things. It's okay. My feelings won't get hurt. All right. We'll talk about the interactions between enteral nutrition and feeding tubes and all this stuff again next lecture. So hopefully that will revisit the same concept again. All right, let's do a little bit about parenteral nutrition, take a break, then we'll come back and talk more about parenteral nutrition. All right, so parenteral nutrition is a name I don't like very much because it's inaccurate. And I'll tell you why it's inaccurate. What is parenteral? What does that word mean?
On the side of enteral, parallel to enteral.
No, so if it's para enteral, that would be correct. So para means next to. It is that's not what that word means, but that's a very good guess though.
Is it IV? Like give an IV?
Okay, I'm getting 2 votes for IV, 1 vote for not oral.
I was all about anything other than
Or buddy.
Okay, now you guys are participating. That's good, but
I
don't
went to the
talk over each
etymology.
other.
I think in practice it means non-GI.
Non-GI. Okay, I got a. Okay, there's a one message that says injectable. Okay. All right. So the answer is actually it means injectable. So IV, IM, or I should say what those are: intravenous, intramuscular, subcutaneous, intradermal, intraosseous, anything that's given injectable, that's what that word means, parenteral. We do not give nutrition in any of these formats except IV. If you give parenteral nutrition into the muscle or subcutaneously or in the bone, that's a problem. Your patient is going to most likely die. So the term parenteral nutrition is outrageously wrong. It should be named intravenous nutrition, but I'm getting out of my soapbox, but it's not incorrect, but let's just go with it because that's what all the literature is using. It says parenteral nutrition. So what that means is, so you guys are not wrong. It's just not the exact definition of it is that it is not given orally or enterally. It is given by injection, but in that particular scenario, when we're talking about parenteral nutrition, it's intravenous. That intravenous axis can be either peripheral or central. So when we're talking central, if you see in the picture on the right, central is usually closer to the heart. So we're talking about like superior vena cava, the subclavian, if you remember from your anatomy and physiology classes. These are big veins that have very wide caliber They have very high rate of blood flow. So you can put stuff that are very highly osmolar there and it will get washed out quickly, redistributed to your whole body very quickly. It takes high osmolar molecules versus peripheral when we're talking about your antecubital fossa. So like this area here in around the elbow or even more distal, these are peripheral lines. So these are much narrower veins. So if you go to get your labs drawn or something for your regular annual check, this is what they're going to use. They're going to access these veins. So much narrower, not a lot of blood flow. So these are going to need a lot less osmolarity going there. All right. So when we're doing parenteral nutrition, we're doing parenteral nutrition when we cannot do nutrition anywhere else, right? Like a patient cannot eat by mouth, we cannot deliver it enterally, or we tried enterally, but we failed. So we have to give parenterally, otherwise the patient is not going to be fed. All right. So access again, central versus peripheral. Neither one of them is the best way. You just have to think of your patient as what is the best way for the patient. So central parenteral nutrition, as I said, this allows you for higher osmolarity, which you will prefer to do that if you're going to have your patient on parenteral nutrition for a long period of time, right? You need the higher osmolarity is going to be with amount of nutrition that you're providing to the best possible, like your patient's TEE or total enteral total energy requirement per day is, let's say, 2000. You can't provide enough carbohydrates and proteins to give that amount and provide that osmolality in a peripheral line. So obviously you're going to use a central line for that case. These patients are going to be in these nutrition formulations for longer than a week or two. Some patients, unfortunately, they stay on parenteral nutrition for the rest of their lives. So obviously you're going to need to have a central line. Versus you have a patient who developed some ileus or something after surgery that resolves within a week. Do you need to be that invasive and give them a central line that goes into very close to the heart that increases the risk of developing infection? You don't really need to. So you can just give them a peripheral line, provide them with some form of suboptimal nutrition through a peripheral parenteral nutrition, and that would be good. So again, there's neither one is better than the other. It's just what's best for the patient that will determine which one you're selecting. So osmolality and how are we choosing the route? So osmolality of parenteral nutrition, similar to enteral nutrition, is going to be mainly dependent on amino acids or protein, dextrose, or carbohydrates, right? These are the big players. Lipids don't really actually provide a lot of osmolarity, like very minimal, if any. So your protein are going to be for amino acid, which is the building block of protein. It's about 10 milliosmol per 1 gram of amino acids. I'm not going to ask you to memorize these numbers, but just to give you an idea of how highly concentrated these ingredients are. Dextrose are about 5. Electrolytes are also play a role in osmolality. And next semester, you'll learn about, in renal, you'll learn about isoosmolar, IV fluids, and hypoosmolar and hyperosmolar, and so on. So you'll learn sodium is the main one. So that's about 1 milliosmol per milli equivalent of individual ingredients. Again, mainly sodium. But the big one is amino acids or protein and dextrose. So these are the ones that the patient needs, just like everything else, but they increase the osmolality, hence they are going to determine your axis central versus peripheral. So the exact number, which that one you need to know the number of, is the maximum osmolality tolerated by a peripheral line is 900 millismol per liter. If you go more concentrated than that, i.e. higher number, then that is too concentrated to be given in a peripheral line. Again, that peripheral line is small caliber, not so much blood flowing there. That osmolality is going to burn through that vein, and your patient is going to have thrombophlebitis, and the tissues are going to be inflamed and possibly even develop an ulcer there. That's how bad that can be. So if you are one day working on making a recipe for parenteral nutrition, which a lot of inpatient pharmacists do, and you check the axis and it's peripheral, you should not exceed 900 milliosmoles. Now, that's important to know because of the consequences of doing it, but at the same time, when you are making that recipe and you're thinking, oh, I care about this patient and I want to give this patient exactly the amount of calories they need through protein and lipid and carbohydrate, to meet their total energy requirement. But if I put these numbers in there, that osmolality is going to go above 900. I guarantee you that's going to be the case. There's not a single patient, even emaciated 90-year-old patient, the requirements are little, it's still not going to get there. It's going to exceed that 900. So it's a matter of balance. Okay, do I want to give them all the nutrients? Probably not. I'm going to have to scale that number, but not too much. So it's still meeting the osmolality requirement. Does that make sense? This is an important concept to understand for the sake of learning this material and also for applying it in your ABIs and also in your practice as a pharmacist, if you do practice in an inpatient setting.
Dr. E,
Yes, ma'am.
I'm sorry, but can you please, it wasn't that it was over too complicated, but could you rephrase that in more layman terms? I just got a little lost.
Got you. Okay. Let me try to think of a different way. So, if I am, let's say I have a patient who is, let's stick with the same patient that we have, the SP, the 35-year-old, and we said that her total energy requirement was 1,909 kilocalorie per day, if I remember correctly. So if okay, and she cannot take food by mouth, she cannot take enteral nutrition, she is indicated for parenteral nutrition. And this is the very first day that we find that out, and the team asked me to make the ingredients for what's going to go into her parenteral nutrition bag. So what I'm going to consider is, okay, she needs that roughly 1900 kcal. How am I going to provide her with that amount? So going back to what the calculations that we did last lecture, which we're going to do something similar to that to figure out, okay, what's the breakdown in terms of carbohydrates, in terms of lipids, in terms of protein. So let's say roughly, which is not correct. Let's say we're going to say a third is protein, a third is carbohydrates, and a third is lipids. Again, that's not correct, but just to make things easy. And let's say the number is, what's a good number to 1800. Let's say that her energy requirement is 1800. So if I'm doing that 1800, a third of that is 600. 600 kcal have to go through as a protein. 600 kcal have to go as a lipid, and 600 kcal have to go as carbohydrate. You guys are following so far?
Yes.
Okay. So in my mind, okay, she needs those 1800. I'm going to give her 600 through these individual macronutrients. The 600 through lipids, they don't cause a lot of osmolality. I don't have to care. I don't have to worry about it. Okay, I'm giving her the full 600. Okay, how about carbohydrates? That gives her some osmolality. So that will raise the osmolality of my final bag that all these ingredients are going to go to. Okay, we're okay so far. Now we go to protein. That, as the slide says, it's 10 milliosmoles per gram. So to give her that amount of the 600 kcal protein, that's going to be a lot of grams of amino acids, which means that will be a lot of osmolality. So if I put all these ingredients in that one bag, that osmolality is going to be really high. It will be like 1200 or something. So, okay, that's fine. I have a bag that gives her all her needs. So she is well nourished. But does she have a central line? She doesn't have a central line, which is, this is the first day we're figuring out that she needs parenteral nutrition. Okay. Does she have a peripheral line? She's hospitalized. Hopefully she has at least one. Okay. Now I have a bag that has 1200 kcal, milliosmol per liter, but she only has a peripheral line in which your max osmolality is 900 milliosmol per liter. I'm a rogue pharmacist and I'll be like, I don't care. I want to give her all the electrolytes, infuse that bag through that line. Then that content of that bag is so concentrated that it will burn through that vein. It will pull all the fluid from the surrounding tissues, and it will start dissipating into the surrounding tissues and causing it to be necrosed. So that's why we try to, instead of doing, okay, giving her the full amount of calories, I'm not going to give her everything. I'm going to give her a little bit. So when I put all these ingredients together, the osmolality of this final product is not that much. It's still less than 900. She doesn't have a central line. We'll figure that out later. And I can give her that back and it will infuse to a peripheral line and it will be okay. Does that make sense?
Yeah, that was a lot better. Thank you.
You're welcome.
Dr. Reed,
Yes, sir.
is there like a specific time that you have to dose like that you need to dose not no more than 600 milliosmoles per liter, or you can give like several boluses of that medication?
So it's not a medication, it's a parenteral nutrition
Sorry, yeah, the
formulation.
parental nutrition. Yeah, sorry.
Yeah, no, you're good. You're good. I'm just making a clarification. We don't generally do boluses. We'll talk about the strategies of delivering parenteral nutrition later. It's typically a continuous infusion or a short infusion over like about 16 hours or 12 hours. We'll talk about that later. But boluses, that would mean that you will have to infuse a big volume over a short period of time, which that it will go, whether you're talking about a peripheral line or a central line, that's still too little of a caliber to take pushing like a liter over a short period of time. So that we generally don't do that. And even if the vein would be able to do that, the osmolality is going to be very high for a peripheral central line to push that big volume in a short period of time. So generally, it's more of a continuous infusion over 24 hours or an intermittent over a shorter period of time, like 16 hours or so.
Thank you.
You're welcome. And the number is 900, just to make sure that we got that number. Are we? We're good? What other questions do you guys have about this? I know this is a little bit difficult to comprehend. You guys are ready for a break? You guys are too
Yes.
tired to even say yes? Was that
Yeah, I'd
someone?
like a break.
Yes, break. We need it.
Oh,
Yes.
okay, it's 2:59 now. Let's meet back at let's see if I'm generous. 3:07. How about that? All right. I will see you guys in a few minutes.
Dr. Heath,
Ma'am.
hi. I
Hi.
think you have your camera, your Zoom set up in a way that you're not seeing the camera. You're missing a lot of action going on. We have a lot of reaction, um, people responding to you with their camera on, but you can't see them. So
I cannot because I can
yeah.
only see a few while having seen the slides and sharing everything.
Mm.
So I would ask you again if you guys are trying to communicate anything, either
Mhm.
say it verbally or put it in the chat box because I can't see all your faces at the same time while having the slides on.
Yeah. So I was just thinking, I was like, oh, you probably don't see the head nods and the thumbs up, and that's why it's like
Again,
silent.
thank you for the point, Tafika.
You're welcome.
All right, I'll see you guys in a few minutes. Okay, guys, we should be back to the slides. We still have some content to go over, so let's get back to it. So we talked about osmolality, how we're going to decide based on that if we are doing peripheral versus central line. Next concept we're going to go over is what goes into parenteral nutrition. So similar to enteral nutrition, we have macronutrients, we have micronutrients, and we have some other stuff. So macronutrients, again, they're protein, carbohydrates, they're lipids. Micronutrients, so that involves electrolytes. You have vitamins, trace elements, and minerals that sometimes are considered micronutrients, sometimes are not considered micronutrients based on which piece of literature you're looking at. It's pretty much the same thing. And obviously fluids. The fluids that go into enteral nutrition don't have to be sterile. If you can use sterile, so when we're talking about the flushes, these are usually sterile flushes. When we're talking about the enteral nutrition formulation itself, it's usually sterile. It doesn't have to be, but you try to use it as sterile preparation to avoid any contamination. If we're talking about parenteral nutrition, that absolutely has to be sterile because that's going into the bloodstream. So that's why it's SWFI or sterile water for injection. All right, so the example I give you earlier about like a third of each of the macronutrient, like as I said, that was incorrect. So that's not the case. That what we do, and this is the breakdown of what we do. So when we figure out what is the patient's the metabolic requirement or the TEE for the whole day, then how do we figure out what comes from which ingredient? And it's usually a range for every single ingredient. So for proteins, it's about 10 to 35. It's roughly about a quarter of it. Lipids are about the same thing. Carbohydrates, again, are going to be the main ingredient. The main ingredients of enteral nutrition, the main ingredient of parenteral nutrition, and the main ingredient of any nutrition that you take in general, unless you're, you're dieting or you're more health conscious than I am. But generally, carbohydrates are going to be the most readily available source of calories. So that's why you see this breakdown is going to be the bigger ratio. So let's start with protein. So for every gram of protein, and that's a number you should know, for every gram of protein, it provides you with 4 kcal. Okay. The protein typically is a combination of essential and non-essential amino acids. If you do recall, essential amino acids, these are amino acids that your body cannot make. So you have to take from an outside source versus non-essential that your body typically makes, but it's still helpful to get it from an outside source as well. So it's a combination of both. Nitrogen content, this is more of an FYI, so you don't have to know that piece of information, but nitrogen is a metabolic byproduct of protein, right? So sometimes we calculate that ratio just to make sure that we're not providing too much or too little of nitrogen. So protein goals. How do we calculate? As you saw from the previous slide, we said it's about 10 to 35%. Well, which number do we choose? It's typically based on what number that particular patient needs. So for a healthy adult, it's about 0.8 gram per patient's body kilogram. Okay. You might see that as 0.8 to 1, 0.8 to 1.2. Generally, the number I would ask is about 0.8 gram per kilogram. So if we go, let's just do practice, easy math. A patient who's generally considered about an average weight of 70 kilograms. What does that number mean? How many grams of protein do they need per day? What's 0.8 times 70?
56.
56, yes. So if I weigh, whoops, all right. If I weigh 70 kilograms and I'm a healthy adult, I need 56 grams of protein per day. Now you don't have to share with me, but you should reflect on your diet. Did you get if you weigh 70 kilograms, did you get your 56 grams of protein per day? I'll let you do that on your own as a self-reflection assignment for the day. But that's usually the range that we go for healthy adults. There are some other complications that require more protein, as when we talked about in the previous lecture. So trauma, stress factors, when we're talking about the stress factors last Thursday, these would require more proteins because your tissues are under significant stress and they are trying to replace any damaged tissue. So they need more protein for these building blocks. So they would require more protein amount. So you see, better patients has the highest level of stress, you would require about 2.5 gram per kilogram. So that's more than 3 times just an average healthy adult. You don't have to memorize that 2.5 gram per kilogram, but just to give you an idea, the number that I want you to memorize in the slide would be that 4 kcal per gram, the first bullet. More FYI information, just so you would know that there's a little bit of literature. There's a lot of studies actually on that concept by itself. So the Aspen guideline recommendations for a starting range is between 0.8 to 2, which is a wide range. In stable patients, that range is a little bit narrower, but critically ill patients, that number go up because they are under significant stress. Okay. So if we go back with the example again that I said, okay, if I weigh 70 kilograms and I'm a healthy adult, I would need 56 grams. So if I need 56 grams of protein today and every day, how many kcals those 56 grams are going to give me? Can you calculate that on top of your head? You don't have to calculate the number. You can just shout out how you think you're going to do that math. So if I need 56 grams of protein, and I know for every gram, there are 4 kcal. So 56 grams are going to give me how many kcal?
56 divided by 4.
Is it divided or multiplied?
Multiplied, it's 224.
What was that, Shani? I heard you said multiplied. What was the final number?
224.
224. Yes, that sounds about right. Yeah, so if you set it up as a ratio proportion and we say, okay, so if I say 4 kcal per 1 gram, so X per, we said 56 grams. So you multiply 56 times 4 over 1, so that gives you the 224. All right, so let's do a little bit more practice here. I think practice is coming up. Yep. Miss SP strikes again. So we're assuming that her daily protein needs, again, this is a range. Let's say that it's 1.2 gram per kilogram. So what is her total protein requirement? And what is the total number of calories this will provide? So remember again, she's 35, she's 154 pounds, her height 66.9 inches, and her total caloric needs are 1909. So same exact math that we just did in the previous slide.
You have to change the pounds to kilograms first, right?
Yes, that is correct. So because it's in everything is measured in kilograms, so the pounds and kilograms, I think if I remember correctly, I was 70 kilograms, 154 divided by 2.2. Here, I'll do the math with you guys on my phone quickly. So 154 divided by 2.2, so that's 70 kilograms, and we know that she needs 1.2 gram per kilogram. So how many grams of protein does she need per day? Okay, I'm getting a lot of 84. That is correct. So that's basically 1.2 gram per kilogram. She's 70 kilograms, 70 multiplied by 1.2 over 1. So that's 84 grams. So 84 grams per day. So that answered the first question, which is how many grams of protein per day? The second question, that number of grams, which is 84, will provide what number of calories? And some of you guys already answered that. So remember again, the number I asked you to memorize is that for every gram of protein, there are 4 kcal that are provided. Okay, getting a lot of votes for 336. All right. So yeah, so we said 1.2 gram per kilogram, 70 kilograms. So that's 84. Total number of calories for 84 multiplied by 4. That's 336. Easy math. Makes sense. If you haven't heard before, went on a break. Tawfiqat told me that I can't see your faces, so I don't see all the nods. So hopefully that's what you're doing now for me to share the slides. I can't see all of your faces, unfortunately. Um, but or the thumbs up. But if you have questions, please either type it in the chat box or just speak up. All right. So take this one step further. So we figured out that she needs 84 grams of protein per day, and that will provide 336 calories. Now you're in the pharmacy, you get an order. Okay, well, she needs 336 grams. How am I preparing that? It's not like I'm going to get my stock bottle, pour it on a scale, and then measure that number of grams. No, you have it in a stock solution that is sterile. The concentration is 10% weight per volume. Okay, so to get those 336, how are you going to get that out of that stock solution? How many milliliters of that stock solution will provide you the 336 calories or the 84 grams? How do you set that up? So think on your classes last year. What does 10% mean? Because if you figure that out, it would be just lining units up next to each other to make sense.
36. How much was it? 336. So it would be
I can't hear you very well, Jose.
it would be 33 points. No. 336. No, never mind. Let me make the math entirely.
That should be 33.6 mils.
Okay, so keep in mind, let's start with the first step, and hopefully I have the right answer on my slides, otherwise that would be a problem. Yeah, I do. Yes, good. You guys made me question myself for a second. All right, so the right answer is 840 milliliters. Let's take it step by step. So we said 10% weight per volume, right? That means 10 gram per 100 ml, right? That's what that word means, or that designation means. 10% is 10 grams per 100 ml, okay? So if we line up the units, if I have 10 grams per 100 mLs, some of you guys are using the 336. What is the unit associated with 336? Was that grams or calories?
Calories.
Calories, right. So we're not using calories, we're using grams, right? So we know that it's 84 grams are providing 336 calories, both important pieces of information, but the one that I need for that answer or for that question is the grams. So if I have 10 grams per 100 mLs, but I need 84 grams, that comes in what mLs? So 84 over X.
340 mLs.
So X equals 84 times 100 over 10, or 84 times 10, which is 840. Did we all get that?
Yeah.
Who didn't get it? Okay, so let's take a step back and figure out again before we like dive into the numbers or get lost in it. First, we figured out this lady, based on her weight and based on needing 1.2 gram per kilogram, she needs 84 grams, right? If she weighed 100 kilograms, but she needed 1.2, she would have needed 120 grams, right? If she weighed 50 kilograms, you multiply that by 1.2, I don't know what number that will be, half of what I just told you before.
60.
I'll take your word for it. So again, it's a weight-based requirement, right? So we figured out she weighs 70 kilograms. She needs 1.2 gram per kilogram. So her total needs of protein per day is 84. Now, the question asks you how many calories that will provide, then you know that there are 4 kcal per gram of protein. So you multiply by 4, that gives you a number of 336. But I have that stock solution of 10%, and I need to get 84 grams out of it. How do I do that? Set it up as a ratio proportion. That gives you 840 mLs. So if I'm making this my imaginary parental nutrition bag for SP, and I'm taking one ingredient after another and pouring it into the bag, the first thing I figured out is how many grams of protein she needs, then figured out how many milliliters. Then I'm going to get my stock solution, pour 840 into that imaginary bag. Now I have just a protein ingredient. Next, we'll talk about lipids, carbohydrates, and how much we're pouring into that imaginary bag. But for now, we figured out how much protein she needs. We're good so far?
Question.
Yes, sir.
So it's 100 ml over 10 grams, then multiplied by 84, correct? It's not 10 over 100, it's 100 over 10. Then multiplied by 84, that gives you 840, correct?
It's however you set it up as long
Because
as
the
you're
way you
lining up the
voted,
units. So 10% weight per volume means 10 gram per 100 ml, or 100 ml over 10 grams. If we set it up this way, if we said 100 mLs have 10 grams, but I need 84 grams. So 84 grams are going to go into the denominator, not the numerator, because the units need to be on both sides the same. So if I
yeah.
say 100 mLs over 10 grams, X over 84, so 84 multiplied by 100 over 10. So that's still 84, 840.
Okay. I mean, the way that I did it was like 100 over 10 grams multiplied by 84, then the grams cancel out, then 84 times 100 divided by 10, that's 840. But
Yeah.
okay, I mean, I understand what you mean.
Yeah, I mean, ratio proportion, you can set it up in so many ways. I mean, that would be the most, what you're describing is the most intuitive ways that you say, okay, and you cancel out the units, so you end up with the unit of the thing that you're measuring, and that way you can double check yourself to say, okay, the question is asking for milliliters, I ended up with milliliters. That's the right way.
Yeah.
Okay.
Thanks.
Other questions? Okay, next is carbohydrates, if I remember correctly. Oh, well, never mind. We're getting there still. So that next question asks, calculate SP's non-protein caloric needs. And you're asking probably yourself now, I don't know what that means. The description is in the name, non-protein caloric needs. We figured out what her protein caloric needs are, which is the 84 grams, which translated into 336 kcal. But if we remember, her total caloric need per day was 1,909. So to meet that 1,909, we got some from the protein, which is 336. That leaves us with the rest to fill with the other stuff. So what is that number? Based on that description that I just gave, you can figure out how we're calculating that number.
Do we just subtract?
Yeah, that's really it.
1573.
What was the number?
1573.
Good. Okay, that's the same number I got. Okay, and Jose is being fancy now, giving me the equation. Good job. Yeah, so it's 1,909 minus 336, which we could say 1,909, which is what she needs per day, minus 336, which is what she got from protein. That leaves you with 1573, is what she's going to get, hopefully, from the rest. And that's the setup, basically. Good. All right, good job, guys. All right, so that's the protein. Transitioning to the next macronutrient, which is carbohydrate. So carbohydrate, another number you should remember, which is the 3.4 kcal per gram. So for every gram of dextrose, that's the carbohydrate we're going to use, every gram of dextrose, you get 3.4 kcal per gram. So almost the same as protein. Protein was 4, carbohydrate is 3.4. The carbohydrate that we're using, as I said, is dextrose. It's mostly hydrated dextrose. So hydrated, that means that it's going to be hydrophilic. So you want a hydrophilic ingredient because you're putting it into the blood. So you want it to be able to disseminate properly. So that's why it's hydrated dextrose. Again, that's going to be the primary source of calories, whether you're talking PN or EN, parenteral nutrition or enteral nutrition. The description here tells you that's the primary source to avoid lipolysis and proteolysis. So to make sense of what that means, lipolysis obviously mean breaking down of protein. Proteolysis mean breaking down of, lipolysis breakdown of lipids, and proteolysis breakdown of protein. So let's take you back to ENP. You probably learned about this. Let's say I'm fasting today, right? I have muscle mass, that's the protein storage. I have, hopefully, I have lipid storage in terms of fat in, in certain parts of the body, and I have carbohydrate storage as glycogen primarily in my liver and some in the muscles as well. When I am fasting, I'm not eating, right? So there's no carbohydrates going in me. How am I still generating ATP to sustain my functions, my body organs? I'm doing that by using carbohydrates, breaking it down. If I'm not eating, where am I getting the carbohydrates? I'm going to get it from my glycogen storage. That should be sufficient for about 24 hours. So if I fast longer than 24 hours, I'm not going to die. My body is going to look for another source of ATP or another source of energy storage that will break it down to produce ATP. So generally, next source is going to be the lipids, which is why if you're dieting, that's how you lose fat, because you're not eating enough carbohydrates to maintain your body weight. So your body starts breaking down fat, you lose the fat storage that provides ATP. If you end up using all your fat, then you move to the muscle as the source of storing lipids, and that's when emaciation happens. And this is what you see in those sad pictures of patients, or not patients, mostly in starvation areas, that you see hollowing of their faces and their body, and you see all the ribs and all this stuff. So that's the normal sequence of things. Obviously, you don't want to starve your patient, so you want to provide them with a lot of carbohydrates so they don't start breaking down their lipids and their protein. So that's the long-winded explanation of that bullet point, which is an important concept to understand, that this is what we're trying to avoid by providing sufficient nutrition. Okay. So next bullet point shouldn't be a surprise to you that a minimum of 50 grams of carbohydrate per day is required to avoid ketone production. So ketone is a byproduct of lipid metabolism. So again, as the next step to break down is the lipids after you don't have enough carbohydrates. So a minimum of 50. That's a number you don't have to remember, but it makes sense. It's a small amount of carbohydrate. If I go eat like a small bag of fries that has a lot more carbohydrates than that number. Imagine that we're talking about total intake for a whole day. So that's the minimum number. Another number you shouldn't have to, it's an important number to know in general, but not for the exam. So you don't have to memorize it, is that the amount of carbohydrates. So the bare minimum is about 50 grams. The maximum of amount of carbohydrates to give for the whole day is 7 grams per kilogram per day. So that's weight based. Beyond that, you're providing too much carbohydrate, even for a non-diabetic patient to tolerate, and they're going to develop hyperglycemia and complications because of that. So again, the main number I want you to know on that slide is the 3.4 kcal per gram, and it's mainly hydrated dextrose. So let's apply more math on this patient. So how many grams of dextrose will be needed to provide 60% of SP's daily caloric needs? Remember, again, we said the 3 macronutrients, there are ranges. So that's why I'm giving you exact number. Like I said, for her protein is 1.2 gram per kilogram. For her dextrose, it's 60%. So read the question carefully. It says how many grams of dextrose, that's what we're calculating, to provide 60% of her total caloric needs, not her non-protein caloric needs. Be careful reading these questions, okay? Because we did calculate her TEE last lecture, which is 1909. We also calculated her non-protein caloric needs a second ago, which was like 1573 or something like that. So out of that 1909, 60% is going to be provided through dextrose. How many grams is that?
1145.
1145. Okay. Grams or calories?
Calories, because it's 1990, and then you're taking 60% of that.
Okay, so that's good, but the question is asking again, grams, not calories. I'm getting very different answers. All right, so let's do that quickly. So we said the total caloric needs for the whole day are 1909. Question is saying she's going to get 60% of those from carbohydrates. So first, let's calculate 60% times what 1909. So it's 1,145.
336. 7.
Yeah. So 1,145 kcal are going to come from dextrose. But that's not what the question is asking. The question is asking how many grams. So how do I convert kcal to gram of dextrose is by the number that I asked you to memorize, which is 3.4 kcal per
0.4.
gram. So basically you're going to divide this over this, and that will give you 337. So if I set it up again, 3.4 kcal per gram, but I want 1,145 kcal per x grams. So x grams multiplied by 3.4 over 145, actually the other way around. So the 1,145 over 3.4. So that
Divided by 3.4.
What was that, Kingsley?
Now we're just mounting that it's 1145 divided by 3.4.
Yes. Yeah. So
Yeah.
that number is 337. Okay. Some of you said 336.9, which is also correct. Okay. So did we get that? Because like I said, I got a lot of different answers. So the
I was
question,
divided by 4. I thought about the traditional like carbo. I thought of it as a carbohydrate too.
got you.
Different.
Okay. So yeah, that's good
Divided
to know.
3.4, not 4. Yeah.
Yeah. So keep in mind that we're talking about dextrose here. So the question here was two questions in one, which is probably why I threw some of you off. So in the previous example, we like went step by step, but this question is a little bit tricky because it's two things that you have to do to keep in mind that it's asking about grams, it's asking about dextrose, it's giving you 60%, it's talking about the total caloric needs. So again, first we said this is her total caloric needs. Walk yourself through the process and talk it out. That way you're less likely to miss the answer. So total caloric needs is what the question is asking. Okay, 1909. Question is saying 60% of that. Okay, what's 60% of that number? That ends up being 1145. Okay. The question is asking about how many grams of dextrose. This is kcal. All right. Well, Dr. E told me to remember one number on that slide, which is 3.4 kcal per gram. Hooray. Now I know how to convert that kcal to grams by setting up ratio proportion. It ends up being 337. Does that make sense? Questions? Comments? Concerns? Complaints? Okay, lipids. Lipids provide 9 kcal per gram. I'm not going to ask you to remember this number because the calculation is a little bit different. Because why would I give you a third number and make things easy? Let's make things a little bit more complicated. That's not my preference. This is how it's calculated generally, is that we calculate when you relate the volume or the weight to the number of calories. In lipids, we don't do that. We just do it by the percentage. Why? I don't know. Someone decided to make our lives a little bit more miserable than it needs to be. But generally, it's available as 20% and 30%, the concentration of it. So that, again, that's weight per volume. So 20% means 20 grams per 100 mLs, 30 grams per 100 mLs. We're not going to measure it that way either. Just remember that the 20% is going to give you 2 kcal per milliliter, and the 30% is going to give you 3 kcal per milliliter. Did you guys follow that? I know, Kingsley, me too. That's the first time I learned about it. I was not happy, but at least it lines up. It's an easy number to remember. 20% 2 kcal per milliliter, 30% 3 kcal per milliliter. So that's the number you need to memorize on that slide. Other information to know, but you don't absolutely have to know that third part is, the third bullet point is that it shouldn't exceed 60% of total calories provided. Why? Because that's number one, it's too much. You're providing a lot of lipids, which can have a lot of other metabolic complications and cardiovascular complications. But two, the immediate problem is that it has a lot of triglycerides specifically. And triglycerides can irritate your pancreas and cause acute pancreatitis, which is a very morbid condition, can be even fatal. So again, you don't have to memorize that number, but just be aware that that's a complication that can happen because of giving excessive lipids. Again, reiteration of the same thing we said before is that lipids do not affect the parenteral nutrition osmolarity significantly. It's, again, the proteins is the big one, the carbohydrates is another big one, and the electrolytes to some extent. Okay. Last bullet point in this slide, non-soybean oil formulations are preferred in parenteral nutrition. Why is that? So most parenteral nutrition that are lipid parenteral nutrition or injectable lipid emulsions, as the fancier, newer name is, instead of saying intravenous lipids, most of them are soybean-based formulations. These can actually cause hepatic dysfunction, which we see quite often in patients on parenteral nutrition. So the shift in the market or clinical practices to use non-soybean oil formulations. However, when you use non-soybean oil formulations, you can end up with essential fatty acid deficiency, and that will get mentioned again in a later slide. But just to know that with soybean oil-based formulations, you have hepatic injury. With non-soybean oil formulations, you have essential fatty acid deficiency. So it's not like one is better than the other. Otherwise, then that worse one would have disappeared from the market. All right. So still same patient. How many calories will need to be provided through lipids? Using 20% lipids, how many milliliters are required to meet her calculated lipid calorie needs? Okay, so let's ignore the second question for now. First question, how many calories will need to be provided through lipids? You're probably asking yourself, wait, what happened? When we talked about carbohydrates, you told me the specific number, which was 1.2 gram per kilogram, right? When we talked about that was protein, sorry. When we talked about carbohydrates, you told me that she needs 60% of her total caloric needs. Why are you not giving me here the ratio? The reason is because that's the last ingredient. We figured out that she needs 1909 in total. We gave her a specific amount through carbohydrates. So we gave her a specific amount through protein. Whatever is left that she needs is just going to be simply given through lipids. So that's why I'm not giving you a specific number. Does that make sense? Someone already gave me an answer. I'm not going to mention the name, but good job. Okay. The second one is not exactly accurate. Okay. All right. So let's ignore the second question for now and answer the first question. So we said calories provided by lipids are going to be total that she needs minus the other calories provided by other stuff. So minus calories provided by protein and calories provided by carbohydrate. So let's translate that into numbers. If she needs a total of 1,909, I gave her 336 through protein, and I gave her 1,145 through carbohydrates. So that leaves me with 428 to provide through lipids, right? Again, that's the imaginary bag. I poured whatever volume that I needed from protein first. Okay, that's the protein. And I got the other stock solution for the carbohydrate, poured a whole ton of volume that gave me a whole lot of calories here. Okay, now I have that little amount that I need to fill with lipids. That little amount by math is 428 kcal. Okay, now the next question is obviously, okay, now I figured out it's 428 kcal. How am I going to give that in volume in milliliter? So if my stock solution is the 20% bag, and we remember again, we said the 20% bag gives 2 kcal per milliliter, the 30% bag gives 3 kcal per milliliter. So if I'm using the 20%, which is 2 kcal per milliliter, I need 428. How many is that in milliliter? So that number ends up being 214, as you see on the screen. So again, ratio proportion, if I say 2 kcal numerator over 1 milliliter in the denominator, I need 428 kcal in the numerator. How many mLs? X. So X equals 428 times 1 over 2, so 214. Does that make sense? What questions do you guys have? Again, I can't see your faces, so you have to type something up or shout it out. All right, I'll take that as no questions.
Pretty cool.
What was that, Kingsley?
That is pretty cool. Pretty straightforward.
Okay, good. I'm glad you like it. All right, so let me just take a look at the content, see a good stopping point. Okay, we have about 7 minutes. We can cover a couple of other things, so we're not behind. All right, so electrolytes. So to recap again, we talked about the macronutrient ingredients. We're going to jump into micronutrient. Macronutrients, we talked about protein. Now that's about 4 kcal per gram. We talked about carbohydrates, hydrated dextrose specifically. That's 3.4 kcal per gram. Then we talked about lipids or intravenous lipid emulsions that comes in 20% and 30%, gives 2 kcal per milliliter from the first one and 3 kcal per milliliter of the latter. Okay, so these are the macronutrients that are going into our imaginary parenteral nutrition bag. Now we're going to talk about the micronutrients. So the first one is electrolytes. So as we said, electrolytes, they do participate to some degree to the osmolality of the bag. They also provide electrolyte depletion because we need electrolytes for our enzymatic reaction, right? And we need it for osmolality to make sure that our intravascular volume is appropriate and we're not leaking fluid inside our tissues, or we're not absorbing a lot of fluid inside our blood vessels and, you know, causing brain shrinkage or brain herniation and all the good stuff that you're going to learn in renal. So these numbers are not, the numbers on the slide are not to be memorized, but just to give you a rough idea of what our daily requirements for electrolytes. Sodium and potassium are big ones. I will say this reference is pretty much everywhere. You'll see these numbers, and these numbers are outrageously high. If you give a patient 2 milliequivalents of sodium per kilogram, that patient is going to be hypernatremic. However, the literature goes by that number for whatever reason, things that goes beyond me. But anyway, again, I digress. But just as a reference to tell you, okay, this is where we kind of go off of when we're trying to figure out how many electrolytes, milligrams or milliequivalents or millimoles that are going into the bag. The big ones are you going to worry about the sodium or potassium, chloride and acetate, as the slide says, that really depends on the acid-base balance. So your acetate are going to give you more of an alkalosis picture versus chloride are going to give you more of an acidosis picture. So based on where your patient falls, you're going to give more of the opposite, if that makes sense. Then calcium, magnesium, and phosphate, these are also important for other enzymatic functions as well. So you adjust all these amounts based on the patient's serum levels. So more FYI stuff. Sodium doesn't come by itself. Potassium doesn't come by itself, and the rest goes for all the electrolytes because they're all electrically charged, and we don't have charges, electrical charges in our body. They're all neutral molecules, so all cations are going to bind to anions and so on until they ionize to do a certain reaction in a temporary fashion. So that's why you're going to have everything bind to another thing, right? So how do I choose between sodium chloride versus sodium acetate versus sodium phosphate versus sodium bicarbonate if I know that I need to give the patient some sodium based on the other attachment too? So if the patient needs sodium and needs phosphate, I'm going to use sodium phosphate instead of sodium chloride. Or the patient is acidemic, I'm going to use sodium acetate to give them sodium, and at the same time acetate, which it gives a little bit of an alkalinic effect. So again, these numbers are FYI, but so you also again to understand that they don't come by themselves. It's a combination. And if I'm giving one ingredient, I'm giving the other as well. All right. So the one big thing that you're going to see in clinical practice that is related to parenteral nutrition is the calcium and phosphate. So calcium is a cation that's positively charged +2. Phosphate is an anion that's negatively charged -3. It can be even higher. So these two highly charged, they love each other, they bind to each other. That becomes a problem when you're making that parenteral nutrition bag. Why? Because they're going to do the same thing. They're going to bind to each other in that tight environment. They're going to bind to each other in the IV line of the patient. and they're going to make precipitates. These precipitates are going to be teeny tiny clots that can travel into the patient's circulation and cause problems. So there is a certain number we try to avoid giving too much of the calcium and the phosphate to avoid causing the patient to have a thrombotic event like a stroke or a DVT or a PE or something like that, obviously. And basically what you try to do is just to avoid giving too much of them. You try to flush the patient and, that's more things that you need to know. But basically the management is going to be, see if the patient needs calcium, you're going to provide calcium outside the bag. If they don't need the calcium, just don't add calcium into the bag generally. If the patient has deficiency of one of the two electrolytes or both, you try to treat the underlying condition rather than giving the supplementation. And if you have to use both of them, use the calcium gluconate instead of calcium chloride, because calcium gluconate is less likely to bind to the phosphate because of just the structure of the molecule. So it's less likely to cause precipitate formation. All right. Let's wait until that for the next time so we can practice more math related to electrolytes. I think that's a good stopping point for today. What questions do you guys have?
Are you going to be posting all the calculations that you did earlier?
Yes, so I don't have access to I forgot the name of the software that you guys have now. I don't have access to that, but I'll share the information with Dr. Falls, and I'll also hopefully the recording went well on my personal device, so I'll share that with her as well. So hopefully she'll be able to post that pretty soon. Thank you again for the reminder about the recording. But again, the golden rule is if you have any questions about anything, please, I'll type up the email address again in the chat box. So you guys have in case you forgot. So if you have any questions, please send me an email and we can go over things together.
Dr. Reed?
Yes, sir.
Dr. Reed?
Yes, sir. Two questions coming up. Go
Yeah.
ahead.
I
think you asked first. Go ahead.
Yeah, I have a question, just general question.
Yes.
Is this like why also we check for IV compatibility, for the calcium, phosphate, and other substances that can maybe form precipitates?
Yes, that's generally why you check for IV compatibility, because some drugs can deactivate other drugs because of the binding together or changing the pH or depending on the formulation of the drugs. But yeah, some drugs that are incompatible with each other that you shouldn't be constitute one with another or have them run in a Y site or have them run in the same IV line or in the same environment. That's basically it, but not necessarily just for the calcium and phosphate. Good question. Kingsley, you had another question or comment?
I was going to ask with respect to the calcium and the phosphate.
Yes.
So would you advise that probably I give calcium as a separate IV line? And then if I have to deal with calcium and phosphate, so I put phosphate in the first bag and then I give calcium as a separate IV line, and that shouldn't be a problem for the patient?
Yes, that's generally what we do. So in real life, what we do is that you have the IV bag for parenteral nutrition has a dedicated IV line and nothing else goes in that line. Then if you need to add something else, which most likely these patients are going to need other IV medications, that they go through another line or lines based on how many lines are available. So in that particular case, if you decide that this patient absolutely needs both calcium and both phos, and if you give all the needed amount in the parenteral nutrition, you'll cause precipitate formation. That way you can give the calcium or the phos separately in another bag, in another line to make sure that that precipitate formation doesn't happen.
Okay, so I just asked, so in practice, for instance, if you were going to give like 100 ml in total, will it be logical to maybe make 50 ml with phosphate and make the other 50 ml with calcium and give them as two separate bags at two separate times?
Well, you don't need to pull both of them out of the parenteral nutrition. You can have either one in the parenteral nutrition. That's fine because generally you try to minimize giving separate IV medications to the patient because with every medication that you hang, there is an increased risk of infection. So you can give, like for this patient, for example, you can give her all her FOS needs in the parenteral nutrition bag, as long as everything is compatible. Take the calcium away and give that as a separate bag or bags in another IV line, if that makes sense or answers your question.
Okay, thank you.
You're welcome. All right. Other questions, comments, concerns, complaints, regrets? All right, guys. If there's nothing else, thank you again for your attention and participation. I will be sharing the material with Dr. Falls. You guys have a good evening.
Thank you, Dr. Ray.
You're welcome.